two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 115, and today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Good evening, everyone.
It's been a while, and today we are back with another journal club. And the trial that we have chosen today for discussion is called as Mercy trial. And this trial was recently published in JAMA, which tested another interesting controversy in ICU, that is around the Meropenem antibiotic, whether we should give it as an infusion or whether we should give in an intermittent dosing regimen. So just to kind of have a little bit of background around the use of beta-lactams in general in ICU, the use of beta-lactams in ICU has been increasing over the last 10 years. And often for hospital-acquired infections, the first line of treatment, at least in Australia and New Zealand, is piperacillin tazobactam. And then obviously for all the resistant gram-negative bacilli with ESBL or Enterobacter, the choice of antibiotics is Meropenem. Now, when you look at the PK/PD data about beta-lactams, is often this concept of minimum inhibitory concentration that needs to be kept in serum of those antibiotics. And certain antibiotics, we have to focus on area under the curve. Certain antibiotics, we have to keep this MIC above the certain range for a certain period of time. As beta-lactams fall in this category where we have to keep the level of antibiotics in serum above the MIC for a reasonable period of time in order to them to be effective. And also one of the concerns that if we don't maintain these levels above MIC, first of all, we are not treating the infection adequately. And the second important challenge is that we are probably causing more harm by promoting the antimicrobial resistance. And that's why it's often kind of challenging in intensive care unit to see what's the kind of ideal dose of these antibiotics, because monitoring MIC in intensive care patient is not feasible, at least at this stage. It takes setting up a lot of serum assays and it's quite cumbersome. Often the values don't come back immediately within the next few hours at the bedside. So making any changes that will impact patient outcomes at the bedside based on the MIC levels is quite challenging, although that should be the gold standard. The other issue with intensive care patients, they all are critically ill and they have augmented renal clearance, and often the standard dosing regimen, which we apply one size fits all for all patients in intensive care patient, is also not the right strategy, because if we are giving Meropenem 1 gram TDS, all adult patients, they have different body weights, they have different renal clearance, and they often will not achieve the target MIC despite giving the same dose in different cohort of patients. So it has been quite challenging. And then the recent studies which has been done on this topic suggested there might be some signal towards the benefit of giving Meropenem as a continuous infusion in order to achieve that MIC, but also avoid antimicrobial resistance pattern emerging due to intermittent dosing regimens. If you look at the surviving sepsis guidelines, they recommended, based on this kind of limited evidence, to kind of change the practices from using the intermittent dosing beta-lactams to continuous or sustained infusion of beta-lactams in critically ill patients. However, the data from the randomized controlled trial on this topic is very limited. In fact, there is none. And in recently Australia and New Zealand continent, we have this Blink-3 trial running, which is also quite challenging to run and has taken a long period of time to complete. So with this background, it's important to look at this trial called as Mercy trial, which was conducted in Italy, Russia, Croatia, and part of the Europe, to see whether there is any benefit of giving Meropenem as continuous infusion versus as an intermittent dosing regimen. So Dr. Checo, can you please walk us through the methodology and the results of the trial, please?
As you said, the Mercy randomized controlled trial was conducted across 31 ICUs in 4 countries, including Croatia, Italy, Kazakhstan, and Russia. The study included ICU patients 18 years or older who had sepsis or septic shock and required treatment with meropenem based on clinician judgment. Sepsis for the study was defined as documented or suspected infection with systemic inflammatory response syndrome and a SOFA score of 2 or more. Septic shock was defined as persistent hypotension after fluid resuscitation requiring vasopressors to maintain a mean arterial pressure of more than 65 millimeters of mercury and elevated lactate levels of more than 2 millimoles per liter. The diagnosis was, at the end of the day, based on clinician judgment. The study was double-blinded. Randomization was performed in a 1-to-1 ratio and was stratified by study center. Who did they exclude? Patients who were treated previously with carbapenems, those with a poor likelihood of survival, with a SAP score of more than 65 points, and patients who had evidence of severe immunosuppression were excluded. In the continuous administration arm, after collection of culture samples, meropenem 1 gram intravenously was administered as a loading dose. This was followed by 3 grams as a continuous infusion over a period of 24 hours. While in the intermittent group, following the loading dose, meropenem was administered intermittently in 3 divided doses of 1 gram every 8 hours. Each dose was administered over a period of 30 to 60 minutes. The common management included the increase in the dose of meropenem if it was considered appropriate by the clinician to do so. And in case of renal dysfunction, the dose was appropriately cut down based on the creatinine clearance. Treatment of sepsis was based on local protocols and based on the surviving sepsis guidelines. How did they calculate the sample size? To calculate the sample size, they took the primary outcome to be a composite outcome of mortality and emergence of pan-resistant or extensively resistant bacteria at 28 days. So that was a composite outcome that they looked at to calculate the sample size. They assumed that the primary composite outcome of 28-day mortality and 28-day emergence of pan-resistant or extensively resistant bacteria would occur in 52% of patients in the intermittent group. And they assumed that a strategy of continuous infusion would result in an absolute risk reduction of 12%. And this necessitated a sample size of 300 patients per group. And that would provide the study with 80% power at an alpha level of 0.05. So that's how they calculated the sample size of 300 patients in each group. How did they carry out the study and what did they find? They screened 896 patients and they included 607 in the study. 303 randomized to the continuous infusion group and 304 to the intermittent administration group. The patients were well matched at baseline. Sepsis without septic shock was diagnosed in 38% of patients in the continuous infusion group and 40% of patients in the intermittent administration group. Septic shock thus was present in 62 and 60% respectively. The most common focus of infection was the respiratory tract, 33% in both groups. This was followed by gastrointestinal tract infections and catheter-related bloodstream infections. The median duration from hospitalization to randomization was 9 days in the continuous infusion group and 8 days in the intermittent administration group. The median time from ICU admission to randomization was 5 days in both groups. The severity of illness was similar in both groups based on the SAPS and the SOFA scores. The median duration of treatment overall was 11 days with meropenem in both the groups. And among 28-day survivors, the median duration of treatment was 13 days. The causative organism could not be identified in 28% of patients in the continuous infusion group and 30% in the intermittent administration group. Gram-negative infections were more common, And among the gram-negative infections, Klebsiella infections were the most common, followed by Pseudomonas, E. coli, and Acinetobacter species. So how about the outcomes? The primary outcome, as I mentioned, was a composite of 28-day mortality, and the emergence of pan-resistant or extensively resistant bacteria was similar in both the groups. 47% in the continuous infusion group versus 49% in the intermittent administration group. So the relative risk was 0.96, which with a confidence interval of 0.81 to 1.13 was not statistically significant. The individual components of the primary outcome, namely the 28-day mortality and the emergence of resistant bacteria, was also not significantly different between the two groups. They looked at a few secondary outcomes as well, including the 90-day mortality, which was 42% in both the groups, the number of days alive and antibiotic free, and the number of days alive and ICU free at 28 days were also not significantly different between the two groups. They also looked at a few post hoc exploratory outcomes, including the length of ICU stay, the length of hospital stay, and the incidence of readmission to ICU. None of these post hoc exploratory outcomes were different, significantly different between the two groups. So these were the main findings of the study. The authors concluded that in critically ill patients with sepsis, compared with intermittent administration, the continuous administration of Meropenem did not improve the composite outcome of mortality and the emergence of pan-resistant or extensively drug-resistant bacteria at day 28.
Thanks, Dr. Chacko. So I guess this study probably won't change my current practice. I think there are many probably limitations of this trial over the advantages. One of the strengths of this trial to start with is probably the largest randomized controlled trial conducted on this topic so far. Now, obviously, we are waiting for Blink-3 trial to be published or completed to start with, which will enroll 7,000 patients and addressing both beta-lactams, including piperacillin, tazobactam, and meropenem. And the primary outcome in Blink-3 will be 90-day mortality compared to 28-day mortality in Mercy-2. Having said that, till we get the results from the Blink-3 trial, this is the largest randomized controlled trial available on this topic so far. It was double-blinded and multi-center and run across 4 different ICUs. However, the external validity of the trial is a bit questionable for me because the part of the world where the trial was conducted, I think the ICU practices are not similar to the rest of the world. So I think we have to take this trial a little bit with a pinch of salt in terms of external validity. The good thing about the study, it was quite well protocolized. There is a good follow-up of the patients. There are only few patients who didn't meet the screening criteria. So most of the patients who were screened met the criteria and received, and then the crossover was not significant. Having said that, the main limitation of the trial is the sample size. And even to look at the baseline mortality assumed by the authors in this trial was 52%. And they aimed for absolute risk reduction of 12%, which is quite a big change just by changing the meropenem from intermittent dosing to continuous infusion. And that's probably why I think this trial is heavily underpowered trial where they enroll only 300 patients in each group. Also, the 28-day mortality outcome is probably not the robust outcome to start with. But often you need to probably ask the question, why will you choose a composite endpoint for trial, which is trying to investigate the 2 different strategies of administering antibiotic? I guess either you stick to mortality and then probably do a 90-day mortality as a robust primary outcome, or you look for the resistance of organisms to that particular antibiotics rather than kind of merging these 2 outcomes together and then looking for a pan-resistance organism. Now, one of the other key limitation is we do not have a data of what other antibiotics the patients received in addition to meropenem, because often if the patient has received meropenem with gentamicin or vancomycin or some antifungal cover, the pattern of resistance will be very different. And also the outcomes will be very different because the primary pathology or pathogen is going to be different. Third limitation is the very large proportion of patients within this trial ended up in receiving antibiotic therapy within the 3 months prior to enrollment in the study. And almost 60 to 70% of the population in this trial actually had some antibiotics in within the 3 months prior to study, which is quite fascinating for me. That means it is a subgroup of patients who kept coming back to the hospital and then had antibiotics recently 3 months ago. And that's going to be obviously contributing hugely to alteration of microbial flora within the community and the resistance pattern at the baseline. And I think that's why checking for pan resistance just with the one antibiotic infusion versus intermittent dosing is not going to be a very good outcome to study. The median time from hospital admission to randomization was kind of 9 days to 8 days, which is quite a lot. Like, why will you randomize someone after 8 days from the hospital admission? Because again, they could have had other antibiotic treatment in a hospital while they were in hospital. And even when the patient was admitted to ICU, the randomization took like 5 days, again, which is quite bizarre for me, because if you want to randomize these patients, you should randomize within first 12 hours to 24 hours of first antibiotic dose. Now, these patients were not probably sickest. Like most of the patients, as you mentioned, had sepsis without septic shock. So again, justifying the continuous infusion in this cohort of patient is going to be a problem. And then none of the last limitation, which is again quite concerning for me, is the total duration of treatment considered within this trial was pretty prolonged, like 11 days to almost 13 or 16 days. And I think, why will you continue antibiotics? Even if the blood culture is positive, usually the standard duration of meropenem for gram negative is 7 to 10 days. And that's the maximum duration. And especially if the source control is already achieved, the duration will become less than prescribed duration. So overall, I think this trial is not that great to kind of convince someone to change their practices. And I guess really what we need to do is wait for Blink-3 trial results to come out, see if there is any signal between the subgroup of patients, or is there a signal with different type of beta-lactam compared to meropenem with regards to use of continuous infusion versus intermittent dosing regimen. So there are a lot of questions are still unanswered. And I know the practices will probably vary between different continents. But again, for me, logistically challenge for using the meropenem infusion or even tazocine infusion is it occupies the one extra lumen of the central line. And that's probably a major limitation or hesitancy in connecting the infusion for me. So that's kind of my thoughts, Dr. Jaco. What's your thoughts and what's your current practice and how it will affect your practice?
I agree with you, Swapnil. One of the main problems with this study that I can see is the composite outcome that they used. They could have either looked at the 28-day mortality or the emergence of resistance. But then, of course, if you're really looking for mortality, then you need a much bigger sample size than this. You would need approximately 1,200, 1,500 patients to look at mortality alone, so which the study obviously was not powered for. And if you look at the previous randomized controlled trial from the Czech Republic that was published, I think, nearly 10 years ago, they looked at clinical cure and microbiological cure. Of course, that study was not powered for any other clinical outcome. So perhaps a microbiological cure, clinical cure could have been one of the outcomes that this present study could also have looked at, which would have been perhaps meaningful as well. And as I mentioned, there is good evidence from pharmacokinetic data as well as from the single RCT that I mentioned. And there are a couple of meta-analyses which have looked at randomized controlled trials, smaller trials, of course, which have compared intermittent dosing versus infusion. And they all seem to come with the answer that clinical outcomes are better with continuous infusion compared to intermittent dosing, particularly in terms of mortality. So if you ask me, in fact, we were looking at the data from pharmacokinetic angle, and we switched our practice largely to continuous infusions at that time. And over the years, we have stuck more and more to administering continuous infusions in most patients, unless, of course, as you mentioned, there is a problem with having a dedicated line to administer antibiotics. So my practice at the moment is to use continuous infusions of beta-lactams. That is unlikely to change with this study either.
That's fascinating. Some parts of the world, the practice is to use continuous infusion. We have more uniform practices where we don't use infusion. We just stick to intermittent dosing at this stage. And that clearly highlights why do we need a robust randomized controlled trial on this topic to answer this question once and all. But I guess to give a credit to authors, I think doing such a trial on this topic is quite hard. And even getting a sample size of anything over 1,000 or 2,000 patients to meet the adequate power, I think it's going to be super challenging. So again, this discussion clearly highlights there is a definite gap in our current knowledge, and that the controversy still exists, where nobody is actually sure whether we should give a continuous meropenem infusion versus intermittent dosing regimen. So I guess on that note, I'll leave you without any kind of strong recommendations on this topic. And I think it will be individualizing the antibiotic regimen to your patient. If the patient is really quite sick or got augmented renal clearance and patient has got a potential to develop resistance pattern, or patient is not responding despite of the standard dosing therapy, I think that there is a potential to consider continuous infusion.
We will eagerly wait for the results of the BRINC-3 trial.
Yeah, that's correct. I guess running the trial has been quite challenging. So yeah, we have to eagerly wait till the trial is completed. So thanks, Dr. Jacko. That's the end of our today's episode. We'll be back with another episode in fortnight's time. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for joining. Till we meet next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.